Hello, a very good afternoon to one and all. Today is the one-day online course of basics of ultrasound musculoskeletal application in the knee. So we are having a list of presentations for today, and just wait for another few minutes, and then we'll start off with the first talk. Just waiting for a few more participants to join in. So in the meantime, I'll just read out the schedule. So we are having totally 4 presentations. First presentation would be on the anatomy of the knee joint with more emphasis on the sono anatomy. This would be done by Dr. Priyanka, and following which we will be having our second presentation. The second presentation is going to be on basic ultrasonography of the knee by Dr. Prashanth Putran. The third presentation will be by Dr. Wiquar, Ahmed, and the topic is sonopathology of the knee. And the last presentation, the fourth one, is going to be application of ultrasound in knee pain management by myself. All right. So I think it's already time. So let us start off with the first presentation. So the first presentation is going to be on anatomy of the knee joint. Dr. Priyanka MP, who's doing her 3 months fellowship with us, would be presenting the first presentation. So Dr. Priyanka, you're with us?
Yes, sir.
Yeah, kindly start sharing your screen. And okay. Almaz, you can mute rest of everyone.
Sure, doctor.
So good afternoon, everyone. So today we are discussing on basics of ultrasound musculoskeletal application in knee. So my topic is anatomy of knee joint. Myself, Dr. Priyanka. So I will be discussing the anatomy and following headings: joint per se, bursa.
Priyanka, your screen is not visible. You have to go to your first slide and then press slideshow.
Okay, sir. So I will be discussing under the following headings: some information on joint per se, then bursa around the knee joint, ligaments and tendons, menisci and muscles around the knee joint, arterial supply, nerve supply, and range of movement of the knee joint. So knee joint is a complex joint. It is formed by all the following joints. Like it is formed on the lateral side by lateral femorotibial, medial femorotibial, femoropatellar, and tibiofibular. All together is the knee joint complex. So they are with each other, and patella slides over the femoral surface, forming a saddle joint there. So it is a condylar synovial joint, 2 condylar joints between condyles of the femur and tibia, and saddle joint between femur and patella. So as you have noticed, the condyles of the femur are comparatively more convex, while the tibial condyles are flat compared to the femoral condyles. So there are several bursae around the knee joint. Anteriorly, the suprapatellar, prepatellar, superficial infrapatellar, deep infrapatellar. On posterior aspect, there are semimembranous, 2 gastrocnemius bursa, popliteal bursa. On medial side, there is pes anserinus bursa, and lateral side, there is fibular bursa. So in this slide, we can see here it is a suprapatellar bursa. Over the patella is the prepatellar bursa, and patellar ligament, below the patellar ligament will be the deep infrapatellar bursa, and superficial to that is superficial infrapatellar bursa. And this is the gastrocnemius bursa. Below the semimembranous attachment is the semimembranosus bursa, and below the pes anserin attachment is the pes anserin bursa. And ligaments, I have taken only few important ligaments. These are anterior cruciate ligament, posterior cruciate ligament, medial collateral, also called as tibial collateral ligament, lateral collateral ligament. Lateral collateral ligament is fibulocollateral ligament, which is because it is extending from femur to fibula, whereas medial collateral ligament is from tibia to femur. Anterior cruciate, the main function of this cruciate ligaments is they provide stability to the knee joint, and they prevent anterior and posterior translation of the knee joint. And posterior anterior cruciate ligament injuries are little commonly seen than the posterior cruciate ligaments. In this picture, we are able to see the posterior. This is the posterior view of the knee joint, and this is the posterior cruciate ligament, which is extending from tibia to femur condyle, and this is the anterior cruciate ligament, and this is the medial collateral ligament on the medial side from femur to tibia. And this is the lateral collateral ligament. This is extending from femur to fibula. So it is also called as fibular collateral ligament. This is the quadriceps tendon formed by the 4 quadriceps muscle that attaches to the base of the patella. This is the patella is almost like a triangular shape. So this is the base, top is the base, and this is the apex. Quadriceps tendon attaches to the base of the patella. And from the apex of the patella starts the patellar ligament to the tibial tuberosity. On both the lateral sides, there is a patellar retinaculum. This is lateral retinaculum, and this is medial retinaculum of the patella. They give stability to the patella. And this is one more fibrous band, which is important for us to know. It extends from the ilium to the tibia. The attachment of it is attached on the tibia to the Gerdy's tubercle. One of the causes of lateral knee pain is because of this fibrous band. Coming to menisci, there are 2 menisci, medial and lateral menisci. So medial menisci is semicircular, whereas lateral menisci is almost circular, like it is 4/5 of the circle. So as I told you previously, this tibial condyles are comparatively flat. So these menisci give the stability when they both align and form the stable joint. And menisci also important in giving the cushion effect, and they give the congruence to the joint. So joint capsule, anteriorly it extends upward underneath the patella to form the suprapatellar recess. Posteriorly, capsule forms into 2 pouches to cover the femoral condyles and tibial plateau. Inferiorly, it contains infrapatellar fat pad and infrapatellar bursa. Medially, it is thickened section of the capsule forms the deep portion of the medial collateral ligament. In this image, we are seeing that the suprapatellar bursa is directly connected to the knee joint. So it is the direct connection with the inside of the knee joint. And there are few fat pads around the knee joint. Those are infrapatellar fat pad. It's also called as Hoffa's fat pad. And on the superior, there are suprapatellar or quadriceps fat pad, and below that is the suprapatellar and prefemoral fat pad. Muscles of the knee. Anteriorly, there are quadriceps muscles, 4 quadriceps muscles which are formed by rectus femoris, and 3 vastus muscles, which give a tendon that attaches to the patella. And there is one more muscle below this quadriceps muscle. It is called as articularis genu. So this muscle, when it contracts, it pulls the fat pad also above. The fat pad which is present here, this is pulled upwards. So it prevents the impingement of the fat pad when with the patella. And posteriorly, laterally, there are biceps muscles, long head and short head. And medially, semimembranosus, semitendinosus, and anteriorly there are few gracilis and sartorius muscles, and inferiorly 2 heads of gastrocnemius muscles. So these 3 muscles, the tendinous attachments of sartorius, gracilis, and semitendinosus together on the tibia is called as pes anserinus. Below this attachment is the pes anserin bursa, one of the causes of medial knee pain. And posteriorly, there is a popliteus muscle, which is a key unlocking muscle, and this is a plantaris muscle. So coming to arterial supply, from the all the genicular arteries are formed from the popliteal artery, and they extend intraarticularly and they also travel along with the genicular nerves. So as we see in this one, so genicular nerves, they travel along with the genicular arteries. Range of movement of knee joint. On complete flexion, it is up to 120 to 150 degrees. Extension is 0 degrees. If it is more than 0 degrees, then it is not physiological. External rotation 20 degrees when the knee is flexed at 90 degrees. Both internal and external rotation when knee is flexed at 90 degrees. External rotation is 20 degrees and internal rotation is up to 10 degrees. So coming to normal axis of the femur, anatomical axis and mechanical axis are not same. Anatomical axis is the line which passes parallel to the femur. That is, when we draw a line in the center of the femur, it is the anatomical axis. And mechanical axis is the straight line. There is a difference of 6 degrees, up to 6 degrees. So joint line is like this because of this axis. So there is a little more pressure on the medial joint line. And one more important thing to know is Q angle. Q angle is formed by two lines. One line from anterior superior iliac spine to the midpoint of the patella, and other line, it is a perpendicular line from the midpoint of the patella, tibial tubercle and midpoint of the patella. Normally, it should be 12 to 15. If it is like any difference in any changes in the Q angle can lead to anterior knee pain. And this is about the anatomy. Then some briefing about the sonoanatomy of the knee. So, important structures that we have to see in the anterior aspect are suprapatellar area, quadriceps tendon, patella, suprapatellar recess, anterior knee bursae. In infrapatellar area, patellar ligament, superficial infrapatellar and deep infrapatellar bursa. Sonoanatomy will be discussed later. So on the medial side, medial collateral ligament, medial meniscus and pes-anserine bursa and pes-anserine attachment. On lateral side, lateral collateral ligament, lateral meniscus, iliotibial band and common peroneal nerve. Posteriorly, popliteal vessels, menisci and Baker cyst pathologically sometimes can be seen. Thank you. I hope this will help for the further understanding of further sessions.
Thank you, Dr. Priyanka. That was a wonderful presentation on anatomy of the knee joint. So anatomy is very, very important, very vital for us. Before we think of doing anything, be it using the ultrasound or any intervention on the knee, knowing the anatomy thoroughly in and out is what is the main prerequisite. So we'll be moving ahead now to the next presentation of the day. This presentation will be by Dr. Prashanth, and this is going to be on basic ultrasound of the knee joint. Dr. Prashanth, you can start sharing your screen. And in the meanwhile, if there are any doubts, kindly feel free to put up your doubts in the comment section, and we'll be answering them. And at the end of the session, we will be again having some time for the Q&A, question and answer as well, wherein we will clear your doubts. So meanwhile, you can type in the comment section if there are any doubts.
So at the outset, I would like to welcome all the delegates for this extravaganza on the applications of ultrasound in managing pain from the knee, that is the knee pain, especially in chronic knee pain situations. All right. So before actually starting the presentation, so when do we start scanning the patient? So the importance of taking a proper clinical history and the clinical examination of the knee is of paramount importance, only after which we should be able to jump into the next step of examination, that is the ultrasound, that is scanning the knee. Almaz, could you mute the rest of them?
Done, doctor. You can continue.
Okay. So then we move ahead with the scanning of the knee. Okay. So wherein the ultrasound has kind of revolutionized pain management, where you can do a lot of interventions, and then it's a very target precise interventions because of the help of the ultrasound. All right. So we have already discussed the anatomy of the knee. So let's look into the sonoanatomy of the knee, after which it will be followed up with the sonopathology and the various applications of ultrasound in terms of any interventions on the knee. Okay. So here we have two pictures wherein the knee is placed in flexion of 20 to 30 degrees. This is important because the extensor mechanism, that is the quads, the quadricep tendon, the patella, they usually attain a concave scenario if the knee is completely extended. Okay, so that is why, so imagine this is the knee. So the anterior aspect of the knee, if you completely extend the knee, the aspect where you want to scan, that attains a very concave kind of a position over here. So we have to flex the knee 20 to 30 degrees to extend the extensor mechanism of the knee, so that we can see the structures properly, because the most important aspect over here is anisotropy. We have to avoid anisotropy because it can lead to misdiagnosis or the wrong diagnosis in certain conditions. So while performing the scan, especially the ultrasound scan, ergonomics is very important, which means to say that where the performer of the scan is sitting and at what angle is visualizing the screen is also very important. The person performing the scan and the screen, so it has to be at a straight angle, so there should not be any torsion of the neck. Okay, and then as I told, the ergonomics about doing the scan I already discussed, that you place a pillow beneath the popliteal fossa so that you have a flexion of 20 to 30 degrees, and then we start the protocol of the knee starts with the suprapatellar area, where you place a linear probe. So far we have discussed about the anatomy. So in sonoanatomy, here you are going to use a linear probe, because the resolution is better, and the structures what we need are somewhere between 1 to 2 centimeters depth. So the linear probe becomes the ideal probe for scanning the knee. Okay, so this is the area where we have it's a sagittal scan of the suprapatellar area, so where you can see the, and now the different appearances of the different structures under the ultrasound is also very important. So ultrasound is just a universe of black, white and gray. All right, so within that, if you see, this is the quadriceps tendon. Okay, a thick quadriceps tendon which appears as multi-layered, which has hypoechoic shadows with linear hyperechoic bands within it. So this is the appearance of a tendon, a normal tendon. And then you have some anechoic shadows over here, and then you have the hyperechoic shadow down. So the hyperechoic shadow over here is nothing but the femur. Okay, and then the mixed intensities, that would be the fat. So as discussed earlier, there are two pad of fat. One is the prefemoral, which is just anterior to the femur in the suprapatellar area, and then this is the patellar bone. This is the patellar bone over here, where you can see the quadriceps tendon coming with patella is nothing but it's a bone within that tendon, right? So the quads tendon inserting over here, and then you have a pad of fat, which is the prepatellar pad of fat. Then we have the prefemoral pad of fat over here, and then the anechoic portion what you see over here is nothing but the suprapatellar recess or the suprapatellar bursa. So normally when we saw in the previous presentation, there were numerous bursae. Okay. So in a normal setting, the bursae is not visible. Okay. Only if there is certain fluid collection, extra fluid collection in that bursa, then only it becomes visible under the scan. So normally it is not visible, but we should have a very good thorough knowledge of the anatomy of where the bursae are located so that we can pick up the abnormalities. Okay. So the same suprapatellar area in a transverse section. So here again we see the hyperechoic femoral the bone shadow, and then the pad of fat, and then we have the quadriceps. So the quadriceps is made up of four important muscles, right? So we have the vastus intermedialis, vastus medialis, vastus lateralis, and then the rectus femoris. So as you can see over here, you have the tendon. So as you move proximally, you will be reaching the musculotendinous portion of that muscle. Okay. And then here again, it is the suprapatellar recess, which is a very important landmark for us because of the various interventions we do in the knee joint. All right. So this is what I was talking about. In the center, we have the vastus intermedius, and above that will be the portion of the rectus femoris, vastus medialis, vastus lateralis, and the femoral bone shadow. Okay. So please keep in mind the ergonomics while performing the scan. Okay. So moving to the next area, that is the infrapatellar area. Okay. So we from this portion we have moved down below the inferior pole of the patella. So now we are seeing the patellar tendon portion. Okay, and that is this nice thick band over here is nothing but the patellar tendon extending from the inferior pole of the patella towards the anterior portion of the tibial tuberosity. Okay, so here this area is very important because multiple important pain generators are located, like the bursae, which was already discussed, the prepatellar bursa, and the deep infrapatellar bursa is located in this area. If there was any bursitis, you would see a anechoic collection in this area in case of a deep infrapatellar bursa, and a superficial infrapatellar bursa would be located in this area. So what is more important is, again, to avoid anisotropy. So we have to be exactly perpendicular to that structure, and then we have to move around to the sides as well, because when we are doing a sagittal scan, we are at the center of the tendon. So you have to move a little right and left to evaluate the tendon as a whole, and also you have to turn the probe 90 degrees so that you can evaluate it under a transverse scan as well. Then of course the Hoffa's pad of fat area over here. So in every slide there would be a slide which is marked and unmarked. Okay, so please do focus on both the slides. So both the images in the slides. So here is the Hoffa's pad of fat area, which becomes important in case of any ACL injuries, and it would be discussed in the next topic, probably in the sonopathology. And as I said, any bursitis and bursal fluid collections over here. Okay. So now we can see that in the same place we have moved towards the medial aspect of the knee joint. So this is the right knee which is being scanned on the medial aspect right now. So if you see, we are approaching this particular in the knee joint. We are approaching this area. Okay, so we are scanning at this level now. So we expect that two bony shadows and a portion between them to be visible, and that is exactly what is seen in the image. Okay, so we have the femoral condyle, the tibial portion, and then the joint space in between. Okay, and in the joint space we are able to appreciate a triangular hypoechoic to hypoechoic structure, which is nothing but the portion of the medial portion of the medial meniscus. which is marked by an asterisk over here. And then the tibial bones. And then we are also appreciating a small hypoechoic area over here. That could be the meniscofemoral ligament. And then the portion of the joint capsule on the surface. Okay. Mind you, we are not that medial where you can visualize the MCL as such right now. Okay. So further, when you externally rotate and place it more inferior, we are able to visualize this particular structure, which is of mixed intensities, hyperechoic to hypoechoic, band-like intensity, echogenicity, sorry, extending from the femoral condyle up to the tibia. Okay, so this is the portion of the medial collateral ligament. Okay, obviously, and then the portion of the meniscus is also visible over here. And you know that the medial meniscus is more amenable to strain in the knee joint because it is closely attached to the capsule and the MCL as well. So from there, sliding down further, okay, we are able to reach the tibial portion, and then here we are looking for the Pesanserine bursa. So again, only if it is inflamed or any bursitis is there, then it is visible, or else it is visible as a thin hypoechoic to hyperechoic line beneath the tendons. Which tendons? The three important tendons, that is the gracilis, semitendinosus, and semimembranosus. Sorry, sartosis, gracilis, and semitendinosus, the GST mnemonic. Okay. And then moving on to the lateral aspect of the knee joint, wherein again we'll be seeing the two bony shadows. That is the marker. The marker is always placed cranially, right? So cranially would be the femoral condyle, and then inferiorly would be the tibial condyle. Again, you can see a triangular portion, lateral portion of the lateral meniscus, and then the portion of the joint capsule above. All right. And then further moving just medially to the patellar bone, we already discussed in anatomy, they did mention about something called as the iliotibial tract, which comes and attaches onto the Gerdy's tubercle, which is onto the tibia. So here you can see a nice band-like structure, which is extending all the way up proximally, distally, coming and attaching onto the Gerdy's tubercle. This is nothing but the process, bony process on the tibia. Okay, anterolateral aspect of the tibia, and that is nothing but the iliotibial band. Okay, which is clearly delineated over here. Okay, then we have to evaluate one more structure which is present laterally, that is nothing but the lateral collateral ligament, again which extends from the lateral femoral condyle onto the fibular head. Okay, so two bony prominences have to be seen along with the band-like structure. So that is exactly what we are seeing over here. This is the lateral femoral condyle, and then the fibular head, and this is nothing but the LCL. Okay, which is seen in this image as well. So as you can see that it is angled. You can also have you can palpate the head of the fibula and then try to adjust your probe as well. And then while doing any ultrasound scan, the part has to be kept in mind: the pressure, the alignment, the rotation, and the tilting. Adequate pressure has to be maintained because this is a very superficial scan while scanning the knee, and you know the bursae are located superficially. So adequate pressure is also important. If you apply too much pressure, that can dislodge the fluid in the bursa, and you may not be able to visualize the bursa itself with the fluid. So keep that in mind and accordingly apply adequate amount of pressure, and a lot of jelly would help in this, because then you would not require to apply a lot of pressure. Okay. Then again in the lateral scan, another structure of interest would be the peroneal nerve, which is located at the neck of the fibula. Okay, fibular neck. So this is the fibular head, and this is the neck portion, and then you have to focus on the probe marker mark D. Okay, that the D placement, you are at the level of the neck of the fibula. That there you would see a hyperechoic to hypoechoic rounded structure, which is nothing but the common peroneal nerve. So moving on to the last aspect of the presentation, that is the posterior knee scan. Okay, so that would be scanned at 3 levels: at the center of the popliteal fossa, the mid portion, and then now moving to the medial and the lateral aspect. So anatomically speaking, you know that there is semimembranosus and semitendinosus over here, and then the biceps femoris at this portion, and then you have the gastrocnemius soleus complex, where the 2 heads of the gastrocnemius muscles are also seen. Okay, so that is what you see in the center, which is commonly scanned. We know that there's a popliteal artery, vein, and then with the sciatic or the tibial nerve. Okay, depending on where the nerve splits. All right, the sciatic nerve splits. Usually it's in the apex of the popliteal fossa, so we are at the midpoint. So here we would expect the tibial, only the tibial nerve portion of that, accompanied by the vessel and that is the artery and the vein. All right. So moving a little medial from the earlier position, we would be reaching at the medial aspect. So you are expected to see the tendons. So the muscle bellies are becoming tendons at this level. So that is what we are able to see over here at this area, a certain hypoechoic portion over here that is marked, that is nothing but the sartorius tendon. Then you would be able to see the muscle belly of the medial head of the gastrocnemius, that is in this area. And more importantly is what is marked in blue over here. It's a bursa. Again, there's a location of a bursa. So that if at all it was positive, then there would be a fluid collection in this region as a crescent-shaped structure over here. One more important structure in this slide would be the relationship between sartorius and the saphenous nerve. We also know that in the anterior thigh, in the knee, we know that we do give the saphenous nerve block over there, right? So this is the sartorius belly, muscle belly, and at this level, just beneath the area between the middle femoral condyle and the sartorius, we would appreciate a hyperechoic mixed intensity structure that would be the saphenous nerve at this level, at the midpoint of the popliteal fossa, medially. All right. So now we have come a little inferior, where you are able to visualize the medial head of gastrocnemius. Again, to talk about the bursal location over here, which is not seen, but the bursal location is located between the 2 tendons, semimembranosus, semitendinosus, and the medial head of gastrocnemius. We have the tendon over here. And another hypoechoic structure which should not be missed is the articular cartilage, which is just above the medial femoral condyle. Okay, in this area. Okay, so the final slide. So the application in knee scan would not be complete if you could not mention about the articular cartilage. Okay, so here you can see that the knee is completely flexed, almost up to 130 to 135 degrees, wherein you place the probe over here just above the patella. The patella translates inferiorly along with the quadriceps muscle. So just above that you place it, and you will be able to see this particular structure, whereas this is the hyperechoic femoral condyle, intercondylar area, along with your trochlear cartilage. So when you translate it medially, you come on to the medial aspect of the superior aspect of the medial condyle, which is the articular weight-bearing portion. So the evaluation of the size of this hypoechoic articular cartilage also serves as a very good indicator in case of osteoarthritic changes, and as a index for treatment, how the treatment, the regenerative medicine treatments are when it is done in that particular patient, and how it is sort of the patient is improving or not. That can be an indicator, but it of course it requires a lot of studies. It's just in the early stages of in the literature as well. Finally, the last slide of my presentation, that would be the again what I spoke about, the evaluation of the medial articular cartilage. As you can see, the graded according. Normally we depend upon the X-ray, and we can also do it in there can be a sonographic classification of the stages of osteoarthritis as well. Okay. Thank you.
Thank you, Dr. Prashanth, for a wonderful presentation.
Thank you, Dr. Javed.
Thank you, Dr. Prashanth. So after understanding the basic ultrasound scan of the knee, let us move ahead to understand pathology of the knee as well, the sonopathology of the knee. So as we are having some time till Dr. Wiquar joins in, I'd like to take this moment to just let you people know of a few announcements. So firstly is the first announcement is that we would be so this is the basic ultrasound course which is going on, and we would be having the advanced course in knee pain management. This course will be most probably next month on 25th and 26th. So the details of registration and everything would be put up shortly for you. So in the advanced course, we would be going, we would be delving into topics a bit more compared to this time what we are doing, and there would be a bit of live demonstrations as well of the examination of the procedures and everything. So you can mark the dates out, which is February 25th and 26th. It will be a 2-day advanced knee pain course. Another announcement is that, as you all know, we have started off with the fellowships. So currently we are doing the FIAP. We have become an accredited center for the Fellowship of Indian Academy of Pain Medicine, wherein we have candidates for the 1-year fellowships. And other than that, we have the other fellowship courses as well, ranging from 2 days, 1-to-1 course interactions to bi-weekly courses to monthly courses, 3 months, 6 months, and full 1-year courses. Coming back to the advanced course, so advanced course also would be online, keeping the COVID situation in mind. This advanced course of this session will be online. Hopefully, once the situation is better, we would be definitely planning to start off with the offline courses as well. So these were a couple of announcements, and next is ultrasound sonopathology of the knee joint.
Good evening, everyone, and welcome to the ultrasound classes at Alleviate, basic ultrasound. So it was a wonderful presentation, Dr. Prashanth. And we will move on to sonopathology of the knee. So before I start off with sonopathology of the knee, knee pain patients are one of the most commonly presented to probably any pain clinic as such. And we need to have a basic understanding of the ultrasound, that is sonoanatomy, as well as surface anatomy. It's very important for us to know where what is, and that makes our life more easy. So basically in sonopathology also, we will be actually segregating it into different sections where it becomes easier for us to cover the pathology aspect of it. And sorry for my voice is a little low and have a bad throat. So we actually divided, and this is the overview of how we are going to start. This is Dr. Wiquar Ahmed, consultant pain specialist at Alleviate Pain and Spine Center, Bangalore, former consultant anesthesiologist at Astra Hospital. So overview of what we will be covering is joint abnormalities in all your arthritis, rheumatoid, and gout, any crystal based arthritis, pseudo gout. And then we'll be going to the cartilage abnormalities and tendon abnormalities, quadriceps femoris injury, patellar tendon injury, and other tendon injuries and ligament injuries as well, all your MCL, LCL and other ligaments. Bursae and cyst will be covering. So before we start also, it is important for us to know a little basic of ultrasound. And ultrasound is We use, because the structures here are quite superficial, we use a linear probe, which is a high frequency probe, which gives less penetration, but better resolution. And the basic concept of ultrasound is the electrical energy which is generated is converted by the crystals in the transducer into your supersonic your sound waves. And these sound waves pass through and they are reflected. At what velocity they are reflected is that is what, as Prashanth told, it is white, black, or gray. And depending on that, we actually formulate and make all this. But one thing we need to also remember before getting in deep is that the probe position. In long axis, always the heel toeing and the toggling in the short axis is important for us to eliminate something called as anisotropy, which is a very important aspect wherein there are terms like hypoechoic, anechoic, and hyperechoic. So it is like how much is reflected back. Depending on that, the structure can be bright white or black, that is your anechoic, and hypo, that it can be blackish or grayish. So depending on that, we can actually separate it. So it's very important for us to eliminate anisotropy before we actually step on and give a diagnosis of certain thing and start treating it. So joint abnormalities, here you can actually see the femur and the tibia. And it's also, I've just kept for a reason that you can also compare. This is again, joint space is significantly reduced with marginal osteophytes present there. And those same can be visualized here. This is in the weight bearing and this is without that. So the joint space reduces significantly. And you can also see the marginal osteophytes. This is probably in the advanced osteoarthritis. Again, the suprapatellar aspect, wherein the structures which all you can see and what defect is there is most important. This is the quadriceps tendon which comes and attaches to the patella. It has 3 layers. The uppermost, the superficial most will be your rectus femoris, then vastus medialis and lateralis, and intermedius in the end. That is the deeper structure. Here you can see this effusion. This is in flexion. This is the prefemoral fat pad and suprapatellar fat pad. This is a femur. Here in extension, you can actually see that there is your normal quadriceps tendon. This is the effusion part of it, which has got connection with your proper joint space. In joint infection, so what you notice in joint infection is this also looks somewhat like an effusion, but you can see that it is more mixed echogenicity. It is not dark or black, which you can see. You can see some spread out this thing. So it is, and you can also see synovial thickening. And we suspect more of infection because of the history of this patient. Here you can actually see that this patient has undergone arthroplasty. So this is a post TKR. If the joint infection is there, this is how it will look as. And this is the femur. And this is the synovial thickening which will be there. And in cases of hemorrhage, again, this is the lateral recess. You can see that there is distension of this area, and mixed echogenicity again is present here with your lateral retinaculum, patellar retinaculum is thickened. Joint effusion with synovial thickening is present in mostly what we see is joint effusion with synovial thickening is present in, which is significantly seen is in your rheumatoid arthritis. I do have a slide for that. And here the asterisk also you can see it. This is the quadriceps tendon below which you can see. And in these cases, which one more thing which you can notice is when we are actually, we are able to see that there is, probably there's a lot of fluid, and we, Dr. Javed will be discussing about the intervention part, but I thought I'll just mention it. And wherein you try to tap it out, but you may not be able to, tap out a lot of fluid from the area. It will look as though there is a lot of fluid present, but you may not be able to, aspirate a lot. And the synovial thickening which will be there, and the probe, when you are giving the pressure, you can actually see. One more thing what you can do when you are actually assessing this area is you can actually give pressure from down. So you can see the distension and the movement of the synovium inside. This is actually a video which you can see we usually use, a hybrid technique. This is a suprapatellar area, a little bit of flexion given there. Local has been given, and you can see the needle there into your suprapatellar bursa, and we are aspirating the fluid. This again, the fluid which is aspirated, that also has to be sent. Anything you tap out, it's better to send it for a examination. And in this case, it looks like an inflammatory fluid, and it can be hemorrhagic. It can be whitish in color. In rheumatoid, you can usually see that. And to rule out even your infections, it's important that you always send it for with the consent of the patient and relatives. Okay. Cartilage abnormalities, again, an important aspect near the femoral condyle. You can see the hyaline cartilage, which usually is seen as a hypoechoic area. It is very even and spread. In this, you can see there is a focal defect in the cartilage at the where you can see the you can see the arrows. And whereas in the medial aspect, you can see that it's a normal hyaline cartilage, which is present with the arrowheads. Quadriceps tendon abnormalities, again, an important aspect, wherein you can see a tendinosis. There is a diffuse swelling and thickening of the tendon and tendon attachment, which you can see at the insertion. Then in this partial thickness tear, you can see that the rectus femoris is intact, but the layers below aren't, and there's a partial thickness tear. And in this, you can see a complete thickness tear with heterogeneous hematoma. This is again quadriceps full thickness complex tear, in which you can see that the distal aspect, the arrowheads which are shown there, is the distal aspect is intact, but there is a split and a full thickness tear where the curved arrows are showing the retracted and you can also see a hyperechoic area in that, which can be correlated with the X-ray. That is the avulse part of the tendon. And again, when you go more proximal, you can see with the normal arrows that a normal tendon exists there. Patellar tendinopathy, when you have assessed the suprapatellar area and you have come below, before coming down here, the one more area which you can assess is prepatellar bursa, if there is any swelling in that area. So the ideal thing is don't put a lot of jelly. Usually it is a very painful area, again, not a very common thing which is presented to the clinic, at least our clinic. But the assessment of the prepatellar bursa will be that you don't give too much of pressure there. You apply a lot of jelly, and you keep the probe supported with less pressure. You can assess that in the prepatellar area. And then when you slide it down, you can actually visualize an area which is connecting your sling sort of an area which is connecting your patella and your tibia, and that is your patellar tendon. In this case, there is a diffuse patellar tendinopathy, which you can see without any significant tear there, and you can see on the contralateral side, which is again normal. Below that, you will have your Hoffa's fat pad. This again an involvement of your patellar tendon. We also say it's as a jumper's knee. And here you can see that the superficial layer is fine. The posterior proximal area is a little thickened. There's no significant thickening. This probably is a case of degenerative tendinopathy. Here you can see that there is a partial tear and with a small speck of calcification which is seen there. And there is the calcification is visualized well. This is a full thickness tear where the distal part is actually cut off completely, retracted. Proximal part is there with your heterogeneous hematoma, joint effusion. This is a case of persistent anterior knee pain. So when you have visualized the cortical defect, you can see very nice cortical defect. Again, this becomes a red flag for us. A patellar fracture which is present there. Gout, again, crystal-based arthritis. Here you can see that the tophi can be seen anywhere, but in this case, the monosodium crystal are seen in the meniscus body. It can also be seen in the popliteus tendon or near the MCL. It can be visualized. So again, what you need to differentiate is between two things, that is gout and pseudo-gout. Pseudo-gout is chondrocalcinosis, in which you have calcium deposition in your hyaline cartilage. That these two things you need to actually differentiate. This is rheumatoid arthritis. Again, you will have synovial thickening and with bony erosions, where you can see the arrowhead there. That is the bony erosion which is present. Again, when you actually aspirate the fluid, it's a very acute presentation with which these patients come. And corticosteroid will actually be the treatment of choice. So we'll come to medial collateral ligament abnormalities. In this, you have, this is the femur and the tibia, and as you know, it is in this case it has got superficial and deep layers. And the deep layer is in the first slide, in the A slide, you can actually see that the meniscofemoral component, there is a tear, and there is also a localized hematoma there present. In this type 2, you can see that the superficial layer is disrupted. Third one, there is an avulsion of the meniscofemoral component. In the fourth, you can actually see that there is a bony avulsion of the superficial layer, the proximal attachment. This is again an MCL calcification, which you can see. One more important aspect which you need to know of MCL is that any calcification as such is you will have an acoustic shadowing, through which when there is a calcification, basically your ultrasound waves will not be able to pass it. So below that, you can actually see the dark area. This dark area can also be seen. There is also a defect which we need to, this thing is refraction. We'll see in the further slides that also has to be ruled out. IT band, again, a common cause of lateral knee pain in tendinitis and all these things. It's a good way where regenerative medicine has got its application. You can see that this is an arthritic knee. Lateral area, you can see the joint space which is reduced in the lower slide, whereas that is the contralateral side, whereas the IT band is normal. In this, the first picture, you can see that there is a diffuse swelling of the tendon pre-insertionally, whereas the open-head arrow a little proximal shows the normal IT band. This is the suprapatellar bursa in a short axis. You can actually see the quadriceps tendon there, also in the middle. It's important for you when you're aspirating that you need to localize. Not many times you will find that the quadriceps tendon is seen very properly and nicely. You need to localize it properly, and your needle, that will determine how you are actually going to go ahead with your intervention. This is again a video in which you can see the needle, and there is that, again, what I was telling, a synovial thickening is there, actually progressing. Right above the needle bevel, you can find the quadriceps tendon in the middle. This is a short axis view. As I mentioned earlier, that these all structures are superficial, so we will be using high frequency linear probe, but in a few patients they are quite obese and we will not be able to visualize easily. And this was one case wherein I had to use we used a curvilinear probe to actually aspirate and give an injection in the suprapatellar area. Again, bursas, infrapatellar bursa can be present, which is superficial to the patellar tendon. Here you can see that the arrows actually are pointing towards your patellar tendon, and you can see that your there is a bursa above that. These bursas can be very painful. And this is an infrapatellar bursa, and right besides your Hoffa's fat pad. In the same view in which you are visualizing your patellar tendon, that is the infrapatellar area, you can see the Hoffa's fat pad, and when you give a little bit of flexion, you can also, when you tilt the probe, you can also visualize your ACL, the distal aspect. So wherein you can again do your needle interventions at that place. But the pathology based ACL, it's always better that MRI is very specific. It's a deeper ligament. PCL intervention and diagnosis a little bit can be done in the posterior aspect. Ligament and tendon, ligaments are more, compact as compared to your tendons. This is also an important thing which you need to remember, the difference between a tendon and a ligament. A pes anserine bursa, again pes anserine, as it was mentioned, sartorius gracilis and semitendinosus. These are three things anterior to posterior, and you can visualize that. This is also the area where you need to pick up where your MCL comes and attaches. You have your genicular artery there. Inferomedial genicular artery can be seen at that same location. In this, you cannot see the shaft, so it will be at the junction, and you can see the pes bursa. One of the common cause of your medial joint pain. So medial joint pain, not mandatory that it should be from arthritis only. Even in a patient suffering with arthritis, you need to actually rule out all these things, because intra-articular any intervention may not help in these patients if you're not going to address it. Meniscal tear, again, a point tenderness will be felt. You actually do your surface anatomy. You need to know it well, and then you place your probe. Here you can see a simple horizontal tear. You can see a simple vertical tear and a complex tear, which is till it goes till your articular surfaces. Extruded meniscus usually seen in your osteoarthritic knees, wherein your MCL is also thickened and your meniscus is extruded, pushed out. Baker's cyst, it is idiopathic and can be secondary to your knee joint issues or trauma, and it can be simple, it can be or it can be complex as well, where in the simple one, it basically where you actually is, this is a cause of posterior knee joint pain. So in this, you will actually be visualizing it between your semimembranosus and the medial head of the gastrocnemius, wherein you can actually see, this is a schematic drawing wherein you can see it. There will be a connection between that to the knee joint. This is an intervention for Baker's cyst. You can see the connection also there. A parameniscal cyst with a meniscal tear. You can see a vertical tear there with a small open head. The arrow heads point towards a parameniscal cyst. There can be loose bodies. Loose bodies can also be seen within your Baker's cyst, wherein it will be seen as calcification. So that is your complex, or it can be ruptured. There can be hemorrhagic cysts as well. So this was it, and when we are actually doing our needling technique, it's also very important for us to know that the needle being bent, just like how we bend our needles for our fluoroscopy guided techniques, it's important that we bend our needles a little, because the concept is that when our probe is there, especially your linear probe, you need to keep your linear probe, the footprint, and your needle parallel to each other. And sometimes it becomes easier for the visualization when you actually in the areas. This was scapulothoracic bursa, in which it becomes easy because that area and all, it's important for manipulation. It was just an added extra point. So hope it was helpful, and thank you.
Thank you very much, Dr. Wiquar, for a wonderful presentation. Sonopathology is very important for us to identify, so that we engage in successful management of the patient's knee condition. Almas, can you make me the host now?
Yes, doctor, you can share your screen.
I will be starting off my presentation now. So we had quite a number of presentations, all focused on the basics of the knee ultrasound. So we went through the anatomy first, and then the basic ultrasound scan of the knee. Then we delved saw the pathological conditions, how they look under the USG, the sonopathology. And the last presentation of the day is going to be applications of ultrasound in knee pain management. I am Dr. Khaja Javed Khan, and let me take you through the overview of today's presentation. It's going to be discussed under the following headings. Before that, I'd like to confirm whether I'm audible clearly and my slides are visible.
Yes, doctor, it's audible.
Okay.
And slides are visible.
Thank you very much. All right, so let's continue. So the overview of my presentation is going to be under the following headings. First is the introduction. Second is looking a bit at the advantages of the ultrasound, the limitations of the ultrasound, applications of ultrasound, a procedure demonstration, literature, and finally the conclusion. Okay, so let's have a look at the introduction. Right, so till now, ultrasound many of a time is associated with a radiologist, right? So whenever we hear the term ultrasound, many of a time it's the radiologist who's the one who is using it. But now what has happened is ultrasound has become a very integral part of the specialty of pain medicine. Ultrasound initially, when it was being used, it was thought to be just an extension to our physical examination. Remember the history clinical examination and the ultrasound, wherein the ultrasound was used for diagnosis. Many of our time for conditions like how you saw in the previous presentation with Dr. Wiquar about the sonopathology, you saw quite a few conditions being diagnosed using the ultrasound, right? So it was more of a diagnostic use. But later on, the therapeutic use as well of ultrasound came to the fore. And now, as we all know, we are in the era of the ultrasound in pain management, and ultrasound is the stethoscope of a pain physician. Right, so let's have a look at the advantages with the ultrasound. Right, so apart from diagnosis, it plays a major role in monitoring of the disease, damage assessment, and the treatment as well. So ultrasound is a rapid method of obtaining the musculoskeletal images. Can assess multiple structures at the same time. It's a real-time dynamic examination. Ultrasound is portable. This best part is there's no radiation and it is non-invasive modality. It's usually well accepted by patients. It gives us the the ability with which we can show the conditions like how the sonopathological conditions. For example, if someone is having a suprapatellar bursa or a knee osteoarthritis, you can use the ultrasound and you can show it to the patient as well. Regarding what conditions are there, many of our time, most of the patients tend to have some kind of an understanding if you explain well. So the patient also becomes a part of your consultation and explanation process. Ultrasound also gives us the ability to visualize needles and the target structures in real time, and making it one of the ideal tools for a pain physician. It's excellent for patient education and to explain the rationale of the treatments. Right, let's have a look at a few limitations. See, one of the important limitations. Almas, can you mute all the participants, please, except me?
Done, doctor.
Am I audible?
Yes.
I think it's still someone is talking.
No, I have muted all.
Okay, thank you. Right, so I'm moving ahead. Let's have a look at the limitations of the ultrasound. One very important thing is operator dependence is paramount, right? And next is there's poor repeatability with the ultrasound. Once an image which you get, then many of the time getting the same image again would be difficult. Of course, it depends on the operator variability. The deeper structures are many often difficult to visualize, even with advancement in the resolution of the transducers. And remember, ultrasound always has a large learning curve. It requires quite a lot of expertise, right? So the more you keep using the ultrasound, the more good you become at it.
Yes, doctor, you are audible.
Yeah, okay, right. So let's have a look at the applications now of the ultrasound. So remember, ultrasound can be used in both inflammatory and non-inflammatory knee conditions, right? And in inflammatory conditions, what are we looking at? We're looking at effusions, the degree of synovitis. In non-inflammatory, we're looking for identification of pathology of the soft tissue structures. Right, coming to knee osteoarthritis, right? So ultrasound has been shown to be more sensitive than clinical examination in detection of joint inflammation in patients with erosive osteoarthritis, as per a study by Khaja et al. In 2010. Synovitis detection in osteoarthritis is considered important because its presence has been shown to be associated with pain, as per a study by Hill et al. So this outlines the importance of the use of ultrasound in a patient suffering from knee osteoarthritis. right? So again, this is a picture. We are seeing the joint lines over here, the medial joint line, and how with the help of an ultrasound we're able to identify the irregularity of the joint margins, the osteophytes, etc. Right, so here we are seeing the suprapatellar effusion as well, which has been discussed in detail in the previous presentations. So applications of ultrasound in the knee are wide and diverse. Right. So let's come to the knee interventions or the applications management of the knee. So quite a number of interventions are done. The common ones are knee joint aspiration is one, knee joint innovations by conventional or cooled radiofrequency ablation, and the knee intra-articular interventions. So this is me doing the knee suprapatellar effusion aspiration. Many of our time patients having the inflammatory or more compared to the degenerative variety of the knee conditions present with effusions in the suprapatellar region. And the ultrasound serves as a great modality for not only diagnosis, but even aspiration. Right. So moving on to the knee intra-articular interventions. Well, intra-articular interventions, quite a number of agents are used for this particular intervention. We have the regenerative medicine options like platelet-rich plasma, stem cells, etc. Prolotherapy is a valuable addition as well. Viscosupplementation or hyaluronic acid, ozone, and steroids, to name a few. Right. So these are the common agents which are used for knee intra-articular interventions: the PRP, the viscosupplementation, the ozones, steroids, etc. Right. So we have a procedure demonstration over here. So this is in a patient. She was suffering from knee osteoarthritis. I was treating her with platelet-rich plasma intra-articular intervention for her knee osteoarthritis. She was having a moderate grade 2 knee osteoarthritis. She completed her first session and she had come in for a second session of knee intra-articular PRP intervention. Let's have a look at the procedure demonstration. My audio is visible? Is my audio heard?
No, doctor. Audio is not audible.
Okay, fine. So basically, this is on the knee ultrasound. What we are doing, as I was telling, a patient who had come in with knee osteoarthritis. So we'll be looking at how we have done this procedure under the ultrasound guidance. So this is me inside the OT. So the patient is in supine position, and with sterile aseptic precautions, we're going to start the procedure. So this is first we are doing the scanning over here, and here, as you have seen in previous slides, I think you can identify the structures from top to bottom. We have the skin, the subcutaneous tissue, the quadriceps tendon, the shaft of the femur, and in the middle we have this space over here, which is the suprapatellar recess. This is seen in longitudinal view. So here is the joint lines, what I'm trying to image. We have the medial joint line over here. And yes, so this is again procedure, what we are starting off. So we can see this black line over here. Let me just annotate this a bit. Yeah. So here first we are giving in local anesthetic, right, to the knee. And you can see the needle over here. This is the suprapatellar recess, right? And we have the needle which is going in and reaching the target point. I'm inserting the cannula over here. And the needle is going in. So we are injecting the PRP over here into the suprapatellar recess. As you can see over here, it is spreading. All right. So let me move ahead to the next slide. So, right. So that was about the intra-articular intervention. And next, we would be looking at a very important intervention, which is the radio frequency ablation. Now, radio frequency ablation, it's a non-surgical, minimally invasive procedure that uses heat to reduce or stop the transmission of pain. Radio frequency waves ablate or burn the knee that is causing the pain, essentially eliminating the transmission of pain signals to the brain. So this is a comparison of the standard versus the cooled RFA. This is the conventional RFA, and this is a cooled RFA. So what you're seeing over here is in the conventional RFA, it is more of an oval lesion, whereas in the cooled RFA, it is a big spherical lesion. And the cooled RFA, usually it produces a bigger lesion compared to the standard RFA, and it is a more preferred modality. Right. So fluoroscopy was used initially for doing the radio frequency ablation. I myself learned radio frequency ablation under the fluoroscopic technique only, and which I was using in my patients as well. So in fluoroscopy, we have the targets over here. This is the AP view, what we are seeing. So we are targeting the three nerves, right? The superomedial, superolateral, and the inferior-medial genicular nerve targets being at the junction of the shaft and the condyle of the femur and the tibia. So this is the AP view targets, right? And a lateral view is taken so that we can see the depth of the needles. So the fluoroscopy was done, but the problem with the fluoroscopic technique was that many of the time the targets were being missed, one. And second is the patient comfort was also compromised. There was a lot of pain, especially if you're using larger bone needles, which are used in the cool radio frequency ablation. So for that, a few articles were also published questioning the accuracy of the fluoroscopic guided genicular nerve blocks. And many of the time in these articles, what was there is, if you're seeing over here, you can see that the needle targets above can be seen, but the blue and the yellow and the green lines are where the actual anatomic targets of the genicular nerve. So you can see over here, especially in the images over here, wherein the needles are there, but the trajectory of the nerves is still quite far. So they concluded saying that the anatomical landmarks currently used for fluoroscopic guided genicular nerve block needed to be revised for more accuracy. So ultrasound guided interventions, I shifted over to ultrasound guided interventions, and how the ultrasound guided interventions, how are they done? Basically, the technique using an ultrasound has same three target location. Of course, the fourth location being optional, which is the suprapatellar genicular nerve. And basically, in the ultrasound, we identify the genicular artery, and then we lesion close to the genicular artery. So here you can see a video. So you can see over here, we have the needle and then the pulsatile artery. The needle is very close to the artery, and that is where the lesion is going to be done. Right. So let's see how the which is better, ultrasound or fluoroscopy. Well, I would say with my experience that ultrasound is definitely a better modality for the radio frequency ablation, at least. How is it better? One is there's no radiation. Real-time guidance is what is done. Soft tissue visualization is possible, wherein even effusions can be visualized. The Doppler is there, which helps in genicular nerve visualization, as the nerves are close to the vessels, the artery specifically. There's lesser pain to the patient. There's no need to be in contact with the periosteum. This is a very important thing. When we are doing the procedure under fluoroscopy, remember, you are hitting the bone and then you're scratching the bone so that you reach the middle of the shaft. Whereas there is no need for this when you are using the ultrasound. You can avoid the contact with the periosteum, and believe me, the pain will be very, very less for the patient. So if the pain is less, there is definitely minimal usage of sedatives, analgesics, and local anesthetics. And cool radiofrequency ablation, as I said, is what is more preferred than the conventional. And both knee cool radiofrequency ablation can be done in the same session if you are using the ultrasound most of the time. Right. So let's have a look at the literature, because whatever discussions we do, the very important thing is to have corroborative evidence as well. So having a look at the literature, so this is a study wherein the efficacy and safety of the ultrasound guided intervention, the treatment for chronic pain in patients with knee osteoarthritis. This is a systematic review and meta-analysis, a review article, and they concluded telling that ultrasound is an effective, safe, dynamic, easily applicable, and non-radiative guidance method for radiofrequency therapy to achieve satisfying pain relief and functional improvement in knee osteoarthritis patients. Coming to the other literature over here, ultrasound guided knee injections are more accurate than blind injections. So this was a systematic review, and they concluded saying that the study showed that ultrasound guided knee injections were more accurate across every anatomical needle injection site compared with blind injections. So this is a testimony to the fact how much of a change, how much of a dynamic change the ultrasound has brought about in the field of pain medicine. Right. So to conclude, I would say ultrasound is definitely the stethoscope of a pain physician. It scores better over fluoroscopy in knee pain interventions, especially cool radiofrequency ablation. Developing an expertise in ultrasound is a very, very vital skill. Thank you very much for your patient hearing. So now the floor is open for any of your doubts. If there are no doubts, then I'd like to thank all the faculties of the presentation. Dr. Priyanka was a great presentation of knee anatomy. Dr. Prashanth sir for a wonderful presentation on the basic ultrasound scan of the knee. Dr. Wiquar sir for a great visual presentation on the sonopathology. And I hope it was a good experience for all of you. As I said, we would be coming back with the advanced course, which would be commencing from the forthcoming months. So thank you very much for your keen participation. And for certificates, as I said, kindly mail your degree or registration certificates to fellowship@alleviatepain.in. Anyone would like to add something, or shall I call it a day?
Yeah, sure, sir. Thank you.
Thank you, Doctor.
Thank you very much.
We'll end the session.
Wonderful presentation, Dr. Javed, sir.
Thank you. Thank you very much, sir.